So our final presenter is Jill Kipnis, and I had the pleasure of working with Jill in 516, which is the Introduction to Professional Issues. Yay, college. Yay. And so she's our final public physio, and she works in the outpatient orthopedic department of St. Paul's Hospital. She's worked there for the past 23 years. She's developed a province-wide physiotherapy post-operative protocol for more than 10 foot and ankle surgeries, and is going to share with us today some of the keys to successful outcomes.
So I'm going to try and share with you my pearls of practice for physiotherapy after foot and ankle surgery. So when PABC first asked me to speak and they told me I had 5 minutes, I thought, what can I share with you that I've learned in the past 10 years in the foot and ankle clinic? So I've decided to focus on 3 key things. So 1, even when it looks complicated, keep it simple. And 2, when the foot and ankle is swollen, try and think beyond ice. And thirdly, try to normalize the movement and avoid a passive roll. So even when it's complicated, keep it simple. I'm just going to share with you a few x-rays that are very typical that we come across in the foot and ankle clinic. So here you have a foot that has first MTP fusion, lots of midfoot fusions. Here we have a tibial osteotomy with a plate and multiple screws. And finally, we have a foot here with a subtalar fusion, multiple midfoot fusions, first MTP fusions, and God knows what other soft tissue techniques. So when you first look at these x-rays, it's pretty easy to freak out and say, what am I going to do? So they're really complex surgeries, but they can be quite simple to treat. So what I suggest is contact the surgeon's office, get the OR report. Often within one procedure, there's 5, 6, within one surgery, there's 5, 6, 7 procedures. So there could be a subtalar fusion, a pronaos longus to brevis transfer, calcaneocuboid fusion, on and on and on. But if you just take each procedure and go step by step, you should be able to treat them. But one really important point that I want to make is if the joint is fused, don't move it. You're laughing. I know you're laughing. But you'd be surprised what has come back, unfortunately. So you really want to be cautious about that. And alternately, if the joint isn't fused, you need to get it moving. So I've had a lot of calls and emails from therapists across the province, and they're worried, the subtalar joint is fused. Can I still mobilize the talocrural joint? Yes, you need to, and you want to get it moving. So the third thing I want to stress is with these very complex surgeries is don't forget to educate your patient. So a lot of what I do is actually just giving the patient confidence that it's okay to move. These patients can be at very high risk for developing complex regional pain syndrome or CRPS with all these crazy nerve signs and increase in pain. So they absolutely need to get moving. And in the foot and ankle clinic, we actually get them moving as early as 2 weeks post-op. Often the post-surgical foot can feel like a real foreign object. So I believe it's our role to teach the patient how to incorporate that limb back into their body. So my second point, when it's swollen, I want you to try and think beyond ice. So it's extremely normal for a post-surgical foot to be swollen for up to 6 months to 1 year post-op. And I know as a clinician, it can be quite concerning when one of these feet walk into your office and they're huge and they're a little bit red and a little bit warm and the patient's freaking out and they think they have an infection. That's not necessarily the case. With these complex procedures, it's really common. However, ice is not effective at dealing with the swelling. So what else can we do? So one of the most effective ways of dealing with the swelling is getting them moving. Get that muscle pump working. Activate them. Secondly, something that we all know but forget about, compression. So often our surgeons will prescribe a compression stocking, but if that's not the case, something as simple as tubie grip can be really effective of getting that swelling out of the foot. And finally, elevation. Again, we all know about elevation, but these patients, our patients, for the first 2 weeks after their surgery, they're instructed to go home and do nothing for 22 out of 24 hours of the day and have their foot elevated 6 inches above their heart. Now, by the time they walk in the door to see you, they won't need that extreme period of elevation, but it's still really important to have that incorporated in their day. So they're up, they're exercising, but they need to elevate. And finally, the last thing that I want to talk to you about is trying to normalize their movement and try as a therapist to avoid a passive role. So I can't stress enough how important it is to get your patient moving and to get them to believe it's actually okay to move and that their hardware isn't going to come popping through their skin, or that if they plantar flex and dorsiflex, their fusion in their midfoot won't fall apart. Everything that we do, joint mobilization, soft tissue release, and all the other techniques that we do are all very important, but I believe what the patient is doing the other 23 out of the 24 hours of the day when they're not with you is probably more important. So I focus on giving them a really good home exercise program, and I usually give them a comprehensive program, but due to the lack of time, I'm just going to focus on one key point, and that's the importance of restoring functional dorsiflexion. So functional dorsiflexion being the foot in contact with the ground and the tibia coming over the talus. I think functional dorsiflexion is probably one of the most important things to restore. We need it for normal gait, we need it for going downstairs properly, we need it for squatting. So what I thought I'd do is just show you 3 little easy exercises that I give my patients that you can take away with you. So first one, patient sitting with their foot on the floor on a little towel, scooting right to the edge of their chair, sliding that foot under the bed, maintaining the foot in contact, you have a nice functional dorsiflexion stretch. Second, patient lying with their foot up on the wall, again, heel in contact, and then just get them to slide that foot down the wall, again, heel in contact, you have that nice stretch. And finally, have them with their foot on a stair or a stool, and then get them to put a little bit of body weight into that, again with the heel in contact, and you have that nice stretch. So just 3 easy exercises that you can go home and start using. There's probably lots others to use as well. So in conclusion, if you leave here and you only remember 2 things I said, I want you to remember to activate your patient, get them moving, and educate your patient. And I'm happy to answer any questions. You can feel free to email me, and my colleague Sandra Squire has kindly agreed for me to put her email up on the slide too, so you don't only email me. She's my other half in the foot and ankle clinic. Thank you.